It's cholesterol month this October. I'm Dr. Ralph Abraham from London Medical, and today I'm going to talk about how I detect cardiovascular risk at London Medical. Patients at increased risk of heart attack and stroke are often identified because their blood cholesterol is found to be elevated, or they might have diabetes, or an elevated blood pressure, or have recently lost a close family member with a heart attack. A positive family history of heart attack or stroke often only comes to light through diligent history taking. Heart attack and stroke are the most common causes of mortality in diabetes. Our understanding of the pathophysiology of atherosclerosis has matured, and markers with better predictive validity have been characterized. They include apolipoprotein B, LDL particle number, and the subfraction of this, the small, dense LDL particle number. Inflammatory processes are now known to be key mediators of transitioning what is a stable, harmless plaque, and we all have them, into a plaque that's vulnerable to rupture, the event that actually occludes a coronary artery and becomes a heart attack. There are also other emerging risk factors: homocysteine, lipoprotein(a), prothrombotic and pro-inflammatory factors, impaired fasting glucose, and of course, pre-existing subclinical atherosclerotic plaque disease. LDL and HDL cholesterol, the bad and the good cholesterol, are imperfect estimates of future cardiovascular risk. Relying on only the LDL cholesterol can vastly underestimate the risk of atherosclerotic plaque formation. And that itself is only part of the story. In deterring someone's risk of a cardiovascular event, a heart attack or stroke, we need to use more sophisticated scores. Some of them exist, such as the Q-risk-free, and although in population terms they do much good, they often underestimate high risk and do not have the capacity to relate to measurements that change with time. At London Medical, we use regular quantitative common carotid imaging with 3D plaque volume measurements, coronary artery calcium scoring, and advanced nuclear magnetic resonance spectroscopic measurements of lipoprotein particles, oxidized LDL, and inflammatory and genetic markers. This allows a more comprehensive approach to the assessment of risk of cardiovascular disease and to tailor treatments appropriate not only to risk, but to rate of atheroma progression. So why bother with all this sophistication? We know that the risk of getting coronary artery disease is substantially reduced by prescribing a statin and lowering the LDL cholesterol, the bad cholesterol. But lower it by how much? How much is enough? What about the patients whose cholesterol is high, but who have no history of heart attacks in their family? What about those with low cholesterol who did have a positive family history, or who had other abnormalities with low good cholesterol or raised triglyceride? Did they have high remnant lipoproteins, which are atherogenic? How would I know my patients were getting better from my prescription? Or worse, needing more LDL lowering? Let us talk about each of these in turn. Modern ultrasound machines can very accurately measure the thickening of the lining of an artery. If done to a specified protocol and repeated, preferably by the same technicians, it is possible to measure change with time, not only of the lining thickness, but also of plaque size and volume. It is not foolproof, and it is, after all, only a surrogate marker for the risk of a cardiovascular event in the future, but it does seem to work reasonably well. Not only in clinical trials of drugs used in cardiovascular disease prevention, but also to guide management in an individual patient. If a patient is showing progression of atherosclerosis with enlargement or development of new plaques, or accelerated thickening of the lining of the artery, then I have always used this as a guide to attempting further lowering of the LDL cholesterol when possible and achievable without side effects, whatever the prevailing LDL cholesterol. This precept has served me well, often leading to improvement in the carotid artery parameters, presumably initiated by the lower LDL cholesterol level. It is now well established that there is, mostly and particularly in younger patients, a direct relationship between LDL lowering and reduction in size of plaques and lumen in arteries, whether in the carotid or coronary circulation. Of course, LDL cholesterol is not the only determinant of progression or regression of atherosclerosis, but assuming no change in other risk factors such as diabetes or cigarette smoking, the LDL cholesterol is usually the main parameter that can be modified and is causal. This enables a physician to make judgment calls on risk when a patient is asymptomatic and has never experienced a cardiovascular event. In other words, in primary prevention. And it allows intervention in a timely fashion, many years before the disease process has advanced to a cardiovascular event, hopefully one that is not fatal, by which time prevention is deemed secondary. Most government guidelines on the basis of published clinical trial evidence only permit a more intense treatment schedule once the horse has bolted. That's after the first cardiovascular event or heart attack. So how has this measurement helped my practice over the last 30 years? One of the least relevant uses came from patients who never wanted to take a statin and did not feel they needed to. And I got evidence that this was indeed the case as we made measurements progressively with time to show that over 10 or even 20 years, they never showed progression of atherosclerosis, even though they had a very high LDL cholesterol. They never needed medication for their cholesterol. These people are small in number and often women, and I must emphasize, and until you investigate and follow up, you do not know that this will be the case. The other side of the coin is much more important and relevant, and that is the patient whose risk is underestimated. This is either because their cholesterol is not that high and they're given just a standard dose of a statin, in some cases the lowest dose possible, but I can show that it is often insufficient to prevent atherosclerosis progression because patients may already have an excess burden of plaque and thickening at an early age. Timely introduction of medication sufficient to intensely treat the LDL cholesterol has been key to giving these patients cardiovascular event-free time for over 20 years. The other test I use at first visit is the coronary artery calcification score. There is a clear, well-established relationship between the amount of calcium deposited in the coronary arteries and the future risk of a heart attack, and one that has led to risk equations based on many thousand patients in the multi-ethnic study of atherosclerosis. Picking up a high score in a young patient gives patient and doctor a chance to set a management strategy for the future that is appropriate to risk and gives the patient many years with which to try and reverse the arterial thickening of the past. Conversely, picking up a 0 score on someone who's over the age of 60 years is reassuring and helps prevent overtreatment or unnecessary expenditure of medical resources in testing and follow-up. Lipoproteins, the complexes that carry fat, cholesterol, and protein in the blood, come in various sizes and densities. And for many years, it was recognized that people with early arterial disease had a particular pattern characterized by small particle size, less than 25.8 nanometers. Simple LDL cholesterol testing is a very crude way of identifying patients at risk, as 50% of patients with a normal cholesterol still carry substantial increases in heart disease risk. Simple LDL cholesterol measurements do not determine the actual number of LDL particles and can be misleading in subjects with small, dense LDL cholesterol, as for an identical LDL level, there is a greater number of LDL particles and apolipoprotein B. Simple LDL cholesterol measurements do not determine the actual number of LDL particles and can be misleading in subjects with a small, dense LDL cholesterol, as for an identical LDL level, there is a greater number of LDL particles and apolipoprotein B and a higher risk. The small, dense LDL particle is actually cholesterol depleted, yet it is more closely linked to atheroma than other particles. If you have many LDL particles that contain less cholesterol in each particle, the conventionally measured LDL cholesterol level will be low, but your heart disease risk will be high. This is particularly common pattern in diabetes, and more than 20% of the population are believed to have this pattern. So it is LDL particle number more than LDL cholesterol amount that is more strongly associated with the risk of cardiovascular events and with atherosclerosis or thickening of the arteries. Smaller particles that are more dense and have less cholesterol more effectively penetrate the cellular barrier and enter arterial walls where they initiate chemical processes that contribute to a heart attack. Increased numbers of small, dense LDL particles increase heart disease risk up to threefold, independently of other risk factors. And 40 to 50% of men with heart disease have predominantly small, dense LDL particles. LDL particle number is among the most powerful tools we have to predict the risk of future heart attack. It provides much more powerful feedback on the adequacy of treatment and is therefore a tool for further reduction of risk. So interpretation of success or failure of treatment depends on knowing lipoprotein particle numbers and not just their cholesterol content. For this reason, these tests, including LPPLA2 and myeloperoxidase, are now routinely used at London Medical. We continue to use the carotid intermedia thickness measurement in a rigorously monitored protocol as a non-invasive way of assessing regression and progression of atherosclerosis in order to make appropriate and logical recommendations on treatment. LDL Medical offers advanced cardiovascular risk assessment and management with facilities for carotid intermedia measurement and 3D plaque studies, advanced lipoprotein nuclear magnetic resonance analysis, and expertise in diabetes and blood pressure management from over 20 experienced consultants, all in one center.